During this live webinar, Dr. Ma from Tennessee Oncology and Dr. Audeh from Agendia will be discussing how identifying a tumor's genomic subtype via blueprint can better inform treatment selection in HR-positive, HER2-negative early-stage breast cancer. Dr. Audeh will discuss the latest blueprint data, its clinical utility, and review applicable cases with Dr. Ma. For those of you that might not be familiar, blueprint is a genomic signature used for molecular subtyping that evaluates the expression profile of 80 genes, classifying tumors as either luminal, A or B, HER2, or Basal-Type. Blueprint goes beyond looking at the cell surface to really evaluate the underlying biology of a tumor and what's driving its growth. Dr. Audeh will expand on this as well. Now, before I hand it over, I would like to give a brief introduction to our presenters. So Dr. Audeh is the Chief Medical Officer at Agendia and is a medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in Los Angeles. Prior to joining Agendia, and in addition to his clinical practice, he served as a former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. Dr. Audeh has also been principal investigator on a wide variety of national and international clinical and translational trials and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. Dr. Ma joins us from Tennessee today, from Tennessee Oncology. She received her medical degree from China Medical University in 1997 and her PhD in molecular science from the University of Tennessee Health Science Center in 2002. Following a postdoctoral cancer research fellowship at St. Jude Children's Research Hospital, she completed an internal medicine residency and medical oncology fellowship at Baylor University Medical Center. For the past 13 years, she has been practicing medical oncology with Tennessee Oncology in the Nashville area. So with that, I will hand it over to you, Dr. Audeh, and you can begin presenting.
Well, thank you very much, Karen, and thank you all for joining us on this nearly last day of October, traditionally observed as Breast Cancer Awareness Month. But as I'm sure we would all agree, at least with Agendia and with doctors such as Dr. Ma and myself, every month is Breast Cancer Awareness Month. And we're very happy to be able to discuss these three interesting and challenging cases, which we believe illustrate the additional information that genomic subtyping provides. So before going into the cases, I simply wanted to set the stage by talking about the two assays that have been applied to the patients we'll be discussing. The first, of course, is the 70-gene MammaPrint assay, which predicts the potential for distant metastasis by studying 70 genes, each of which is involved in the complex process of metastasis, which is why MammaPrint is really considered to provide a functional gene expression profile of metastatic capability and stratifies breast cancers into either low or high risk, in addition to further categories, which I'll mention in a moment. The second assay, which Karen described and which I will also be discussing, is the blueprint assay, which looks at a different aspect of breast cancer biology. It is the signaling pathways that are downstream from activated surface receptors, at least in the case of hormone receptor positive breast cancers or HER2 positive breast cancers. These are then classified as either luminal type, being a hormonally driven breast cancer, with 58 genes in the luminal signature to correctly identify tumors that are dependent on estrogen signaling. The HER2 type, tumors that are driven by HER2 signaling. And then lastly, the basal type, in which there isn't a clear surface receptor driving growth, but a number of genes that are known to be involved in basal type biology. As you know, most basal type tumors are triple negative in terms of surface receptor analysis. However, as we will be discussing, there is a very important cohort of hormone receptor expressing tumors that are genomically basal as detected by blueprint, with a biology and clinical behavior much more similar to triple negative breast cancer. Blueprint was developed after the MammaPrint assay, and the initial validation publication is presented here. It's important to show that Blueprint has a 92% concordance with the original intrinsic gene set subtypes. but only a 9-gene overlap with one of the other subtyping assays, PAM50, as shown here in this Venn diagram. So together, Agendia's MammaPrint and Blueprint are performed on the same tissue sample, either a core biopsy or resection specimen, at the same time, and we provide this comprehensive gene expression profiling. With MammaPrint, of course, there is low risk, which is in the positive index range, or high risk in the negative index range. But we further stratify low risk into ultra low and low, and high risk into high 1 and high 2, with the separation between these categories at minus 0.57 in the high risk range. The addition of Blueprint provides further information in that we add the MammaPrint to the Blueprint result. And in the case of hormone receptor positive HER2 negative breast cancer, as we are discussing today, we identify 5 distinct genomically defined subtypes of hormone positive HER2 negative breast cancer, each of which has important prognostic implications as well as implications for therapy selection. Now, as I think you know, the primary emphasis of using gene expression profiling in breast cancer, and particularly with MammaPrint, has been to focus on the low-risk genomic profile and identify women who could safely avoid chemotherapy. However, in more recent data, which we will be discussing today, the focus has shifted to the high-risk MammaPrint and what we can learn from identifying MammaPrint high-risk cancers as either high 1 or high 2, and how that may have an impact on therapy selection and timing of surgery versus systemic therapy. In fact, as you can see from this slide, the consideration of neoadjuvant chemotherapy is raised by the identification of high-risk MammaPrint profile. Now, in order to apply genomics to a neoadjuvant decision, we must be able to look at the core biopsy sample prior to surgery. And I'll show you data regarding that in a moment. The high-risk aspect of MammaPrint has been the subject of some important data presented at ASCO just a few months ago. Here's one cohort that was described looking at high-risk 1 and high-risk 2 breast cancers and their benefit from anthracycline in the hormone receptor positive population, presented by Dr. Joyce O'Shaughnessy, and then further data looking at the immune activation state of MammaPrint high-risk tumors, particularly high 2, and their likely sensitivity to immunotherapy. These sorts of studies require that the genomic analysis be known prior to surgery so that a neoadjuvant decision can possibly be made if appropriate. And in order to rely on the core biopsy, we needed to show that the genomic result on the core is equivalent to what we would receive if we waited until the surgical resection and analyzed the tumor at that point. So we did publish a few years ago a concordance analysis of the genomic results of MammaPrint and Blueprint, comparing the result on core biopsy versus the result on the resection specimen performed 2 to 3 weeks later without any intervening therapy. And you can see here with these very tight cluster diagrams that there is very high concordance between the result on core biopsy and resection, over 90%, similar to what we accept for immunohistochemistry and actually better than fluorescent in situ hybridization concordance. So with that in mind, showing that a core biopsy sample can indeed be routinely used for genomics, let's move on to discuss our cases. And for that, I will turn to Dr. Ma to discuss her cases with us.
First patient is a very young lady, 35 years old. She self-palpated a right breast nodule earlier 23. So at the time on imaging, the tumor is right, was around 19 millimeters on mammogram, about 20 millimeter on exam. Of course, MRI always showed the tumor is a little bit larger at 28 millimeters. So this is about a T1C, T2 tumor on initial evaluation. Went ahead, had a biopsy, came back as a high-grade invasive ductal carcinoma, and immunohistochemistry stain showed ER to be weak 1+ at 40%, PR 0, clearly at least ER weak tumor and somewhat of a discrepancy between ER and PR expression. HER2 is low on IHC, non-amplified, and proliferation rate was extremely high, 81%. So, sorry.
No, I just want to ask you, so based upon what you know so far, what would you anticipate your likely therapy choice based in the absence, let's say, of genomic information?
Well, this is the typical patient that, these days I would be a little suspicious of the ER pathway because the ER stains weak. There's an ER-PR discrepancy in a young patient. This actually will be a patient I would be questioning if we should consider neoadjuvant treatment. And these would be a patient I would definitely prefer genomic profiling in the neoadjuvant setting on a
Yeah,
biopsy sample to give me more information. Yeah.
very good. So given her young age and the clinical stage, which is sort of on the border between T1 and T2,
Mhm.
with clinically uninvolved nodes, at least by physical exam, um, one question that certainly is raised by her age is whether she may be carrying a germline mutation. Did you perform germline testing?
Yeah, we did. We did. She actually does have a BRCA1 mutation. We found out all these are done simultaneously, so these information trickle in over time. So of course, knowing that, it further increased the odds of her having actual basal type, despite ER being positive on the IHC stain.
Yeah, very interesting. So a germline BRCA1 mutation, but
Mm.
expressing estrogen receptor, at least in a lower range and completely negative for progesterone, does raise some questions about the ultimate biology of this breast cancer. So you mentioned that even with a somewhat smaller tumor size, you would be considering neoadjuvant therapy rather than going directly to surgery. Can you expand on what you would consider to be the benefit of going directly to neoadjuvant therapy in a tumor such as this?
Well, the qualifier for that is I was suspicious of this tumor being basal type. If the profile come by non-basal small tumor, uh, I'm not sure. The current data, I know there is definitely strong ER low data neoadjuvant, um, but it's not my common practice to do neoadjuvant treatment if the tumor is clearly resectable. So that's not my common. But in this case, I mentioned that because I was suspicious of this patient having a non-hormonal driven, more of a basal type. Yeah.
Yeah. Well, I think your hunch was uh, correct because in performing the mammoprint and blueprint as you did on the biopsy specimen, um, this came back high risk with a mammoprint index of -1, about as high as one can get, and basal type. So your suspicion was certainly supported by the mammoprint and the blueprint, indicating a more basal biology. And so let me digress for a moment just to describe some of the data that we've generated regarding this basal subtype, which I think has been the basis of your decision making for this particular patient. In 2022, we published an analysis of this subtype, hormone positive breast cancers that are genomically basal and behave clinically very much like triple negative breast cancers. This was published in JCO Precision Oncology, looking at a cohort that had been enrolled in a trial known as NBreast, a neoadjuvant study. In this study, we found that of the hormone positive breast cancers, between 15 and 28% fell into this basal category. Uh, Genomically, they had no evidence of active estrogen receptor signaling, despite the fact that the IHC could be quite high, even up to 99%, as I'll show you in a moment. And there were no specific pathology characteristics that would always identify these patients. They do tend to be higher grade, but they are not all grade 3 by any means. And they do tend to have higher Ki67s, but not at a reliable threshold that will always find these cases. Very much like triple negative breast cancers, they are highly chemosensitive, much more than most hormone receptor positive breast cancers, with relatively high PCR rates, but also, unfortunately, like triple negatives, they have poor outcomes if they don't achieve a PCR. The PCR rates are shown here. This was from the NBREST trial, again published a few years ago, where we looked at the rates of pathologic complete response in a cohort of hormone receptor positive, HER2 negative breast cancers, defined first by immunohistochemistry, where the overall pathologic complete response rate of this group was 10%. But when we further stratified them with blueprint and mammaprint, we get more precision in the prediction of the likelihood of pathologic complete response to neoadjuvant chemotherapy. For luminal A, which are luminal by blueprint, hormonally driven, but mammaprint low risk, the PCR rates to chemotherapy were very low, only 2%. For luminal B tumors, mammaprint high risk, either high risk 1 or high risk 2, and luminal, a somewhat higher rate, which is 6%, but maybe actually as high as 20% if we have a luminal B high 2. And then lastly, we have this group of hormone receptor positive, HER2 negative patients that are genomically basal with a much higher rate of pathologic complete response, 34%, very similar to a true triple negative. And as I mentioned, the frequency of this subtype may be as high as 28% in high-risk mammaprint cancers. Not only is the PCR rate elevated, like a triple negative, but the outcomes are also very similar to triple negative breast cancers. But the question is certainly frequently asked, how can a breast cancer that expresses estrogen receptor protein still be genomically basal? Are these not simply the very low ERs of 1 to 9%, where the presence of estrogen receptor is really not indicative of the biology of the cancer? And the answer, as shown here, is that these cancers can express very high levels of the estrogen receptor protein, which appears to be defective in its signaling capability. The molecular answer that we have analyzed is that this is due to a splicing abnormality of the mRNA coming from the ESR1 gene that yields the presence of protein that is missing exomes from the original mRNA that produces a non-functional protein. So here you see the range on the left of immunohistochemically positive, hormone-positive basal breast cancers. And as you can see, while there is a clustering at the low level of ER expression, the estrogen receptor positivity can be as high as nearly 100%. Progesterone receptor is somewhat more informative in that it is rarely above 50% and most often in the lower range, as is the case with your patient. But it indicates that the level of estrogen receptor is not indicative of whether you have a basal breast cancer. In fact, any level of estrogen receptor could still be compatible with a genomically basal breast cancer. And on the right is a reiteration of the pathologic complete response rates, showing the ER-positive basal in blue compared to a true IHC-defined triple negative in the gold bar. Very similar there and quite different from luminal tumors defined by Blueprint as luminal A or B. The 5-year outcomes are also very similar to triple negative breast cancers. Here you see the 5-year overall survival of these hormone receptor positive basal breast cancers shown in red compared to luminal B breast cancers shown in blue. And I'm calling your attention now to the solid line, which are the patients who achieved a pathologic complete response. If they were treated aggressively enough to achieve a PCR, they do relatively well with an overall survival at 5 years of over 82%. While if they do not achieve a PCR, if they are not treated aggressively enough, they do the worst of almost any cohort of hormone receptor positive HER2 negative breast cancers, very similar to the kinds of neoadjuvant curves we see with triple negative breast cancers. Another aspect of this biology, which I think is very interesting and we continue to explore, is how this hormone receptor positive basal entity differs in its frequency based upon genetic ancestry, at least in terms of self-reported race. Here we show data that was presented at ASCO and with follow-up at San Antonio, as a matter of fact, and now in manuscript form, from a collaboration with Vanderbilt University, where we compared a cohort of hormone receptor positive Black women with breast cancer and compared to a clinically matched group of white women, non-Hispanic. And the important finding here is shown in the red box, where the incidence of hormone receptor positive basal breast cancers appears to be twice as high in self-reported Black women as opposed to white women. And while there are many reasons for the poorer outcome for Black women with breast cancer compared to white women, we believe that one reason for these poor outcomes may indeed be undertreatment of this entity if it's not recognized and treated aggressively enough. Importantly, when we looked at another ethnicity, women of Latin American descent, in a spotlight poster presented at San Antonio last year, we saw something similar, here presented by Dr. Mazzucanola from UT Health San Antonio. When we looked at a cohort of Latin American patients compared to non-Hispanic white, we also see, as shown here in the red highlighted prose, that this blueprint basal subtype was also more common in women of Latin descent than non-Hispanic white women. Again, something that is associated, we believe, with genetic ancestry in some way. So, coming back to your case, Dr. Ma, can you explain what you decided to do with this case?
Well, so, with her came back basal type, her tumor right hugging the line of 2 centimeters. We talked to her about the Keynote 522 trial, the regimen. And so, of course, at a young age, we decided to be aggressive. So she had the carboplatin with Taxol, with Pembro, followed by Pembro, NAC, the entire regimen. And she tolerated well and had a good response.
So let me ask you,
Mm-hmm.
while I can understand that the Keynote 522 data, which of course came from triple negative breast cancers that were estrogen receptor negative, certainly makes sense for a tumor that is believed to be triple negative in its biology. This patient had 40% positive estrogen receptor, although the PR, was clearly negative. So I think it's a very interesting decision to apply what is essentially a triple negative approach to this patient, particularly because of what was learned from the genomic analysis. The surface receptor appeared to be misleading in the sense of understanding what the true biology of this breast cancer was. So as you went to mastectomy, as I understand it, the result was very good.
Yes, we were very happy for her, had a complete response. And so, I think right now the decision actually is to what kind of endocrine treatment she's gonna have. Yeah.
Yeah. And so at her age, at 35, I guess there are a few options. What are you choosing to do with her as far as postoperative endocrine therapy?
Well, that's another benefit of the blueprint profile to me in this case, because it's a bit of I'm more comfortable knowing that her tumor is more driven by the basal pathway instead of the hormonal pathway. But I'm not ready to, for a young patient, I'm not ready to give up endocrine treatment. I don't feel the data is there. So we decided to give her tamoxifen. Yeah.
Oh, yeah. So tamoxifen as opposed to
AI. Yeah.
full bore OFS and AI.
In her case, a little bit different. She will eventually have oophorectomy because of BRCA1 mutation.
Yeah.
But even if not, I probably still choose tamoxifen without ovarian suppression because of the major quality of life difference for a young lady like that. Yeah.
Yeah. Well, and she had an excellent response to neoadjuvant therapy, and as you say, for protection against her risk of ovarian cancer, she'll ultimately benefit from a bilateral prophylactic oophorectomy anyway. But it is certainly a question that is appropriate to raise, given what we know of basal breast cancer biology. Would endocrine therapy really be effective in a cancer where we believe the estrogen receptor is not signaling? Unfortunately, we do not have data in which hormonal therapy was withheld from these patients to prove that anti-estrogen therapy is not helpful. So it remains part of the standard of care as you are observing with this case. So let me go on to the second case as well. If you want to give us the initial presentation.
Is another relatively young lady, 43-year-old, and just got diagnosed earlier this year. Just routine screening mammogram showed a 13-millimeter nodule of the left breast. So again, this measure a little larger on the MRI scan is 3 centimeters. And so we went ahead, did a biopsy, advanced a slide.
Oh, sorry.
So we went ahead and biopsy, and it came back again, high-grade invasive ductal, very suspicious for lymphovascular invasion, another high-risk feature. And we did a stain, and this time again, ER is low, 40%. Again, discrepancy between ER and PR 0. HER2 came back low, non-amplified. KT7 is not as dramatic as the previous young lady, but still elevated 40%.
Mm-hmm.
So this is a patient, again, in my mind, I will be suspicious of the genomic profile. I would prefer to send a genomic profiling in the neoadjuvant situation on the biopsy sample.
Mm-hmm.
Unfortunately for this lady, when we try to send the testing, the DNA, the RNA quality on the biopsy was not sufficient for testing.
Yes.
So, go ahead. Sorry.
But before we go on, I just want to address this issue because initially, as a clinically low-risk patient with a clinical T1C N0, I did want to address the point that there are some who question the value of genomic testing in a clinically low-risk patient. I think this patient, as well as the one that you just presented, case 1, are indicative of a relatively low clinical risk in terms of tumor size and negative node patients whose tumors are still quite aggressive in terms of what we learn from genomic profile and can help guide therapy even in a clinically low-risk patient, particularly one that you believe may behave like a triple negative. So as you did with the previous case, you ordered mammoprint and blueprint on the biopsy sample. And in this case, it came back uninterpretable because of poor RNA quality, which of course has to be at a certain level in order for us to accurately run the assay. One may ask, how often does this happen? And in our analysis of many thousands of cases in our laboratory in Southern California, where we actually receive a large number of needle core biopsies as well as resection specimens, the rate of poor RNA quality is only about 2% on core biopsies. In fact, it's somewhat higher on resection specimens, closer to 3 or 4%, because of the poor penetration of fixative on the whole tumor. So even with this negative result on the first biopsy, it is not because it was a core. It was simply, in this particular case, what we do see in about 2% of cases. So you did take the patient on to surgery, as I understand it, and she had a left lumpectomy and sentinel node biopsy. And could you describe the results?
Yeah, so the patient was anxious because to repeat testing would take a longer delay. So we went ahead to surgery. And so it came out the tumor was, not much bigger than was measured on the mammogram. And so lymph nodes were negative. So we actually, in this case, I remain suspicious. Even though we went ahead of surgery, I still went ahead, had a genetic profiling on this clinical low-risk patient.
Yes, and here are the results. High risk 1 this time, somewhat below that cutoff of minus 0.57. But interestingly, the blueprint was again basal. And here's the appearance of the report. And you'll see the footnote here that indicates that these patients were tested prior to the release of our newest report format, which came out in August of this year. So what you're seeing here is what the old report looks like. The new report has improved considerably, but you can see that the index is shown here at minus 0.413 and the subtype basal. So again, you've got a basal breast cancer now without having the information prior to surgery. Would you have considered neoadjuvant therapy for this patient if you had known that they were basal to begin with?
I would. I do think the pathological response in the basal type is highly prognostic. I would have if I knew that up front, because I would give a patient the same regimen. I don't think a patient will get any extra treatment than would have gotten anyways. In a neoadjuvant setting, I think it'd be more informative and beneficial. Yeah, I
Yeah.
would have. Yeah, yeah.
Well, certainly, if you believe, again, that these tumors are biologically much more like triple negative than other luminal cancers, according to the NCCN, they advise neoadjuvant therapy for tumors of this clinical stage, T1C and 0, if they're triple negative. And we now have a hormone positive subpopulation that meets these same criteria. Now, I just again want to digress for a moment to look at data from our large registry trial, the FLEX trial, which enrolls women who have standard of care mammoprint and blueprint testing. And the study itself allows us to obtain whole transcriptome data on these patients, as well as analyzing other aspects of their biology. But we were very curious to see the rate of neoadjuvant PCR in patients as stratified by mammoprint and blueprint. So we looked at 214 of these cases. And as we saw with other studies, such as the I-SPY trial, for example, there is clearly a difference in the likelihood of achieving a pathologic complete response with neoadjuvant chemotherapy, depending on how high the mammoprint index goes in the negative range. Your patient, Dr. Ma, in this particular case, was at the upper limit of high 1, while you can see that high 2 does have a higher rate of PCR. But when we further stratify them by blueprint, it is the basal biology that really seems to be driving the likelihood of PCR. In this particular analysis, there were very few high 1 basals, and in fact, they only make up about 2 or 3% of all the high 1 mammoprints that we see. Most basal breast cancers are indeed high 2, and it's the basal biology that seems to be driving the chemosensitivity, producing these high rates of PCR. And when you add what we already know about the 2% PCR rate for mammoprint low risk patients that are luminal, what we're able to show is a high degree of precision in predicting the likelihood of a pathologic complete response when considering neoadjuvant chemotherapy for a hormone positive HER2 negative patient. One interesting aspect that we also looked at was whether the chemotherapy regimen might affect the likelihood of achieving a PCR for this type of patient. So in data from this same analysis from the FLEX trial, which incidentally now has over 18,000 women enrolled in this trial across 100 sites in the US, when we looked at this neoadjuvant cohort by which regimen they received, we found interestingly that for high 1 patients, the likelihood of a PCR was the same whether they received Taxotere Cytoxan for 4 to 6 cycles or ACT neoadjuvant therapy, around 7-8%. When we looked at high 2, it was quite a different story, with the only PCRs being achieved in the ACT group and none in the TC group, although the numbers here were small. And Blueprint adds even further granularity, showing that for luminal B high 2, the PCR rate 22% goes up to 42% for a high 2 basal. So in both cases, I think having the basal biology really is driving this chemosensitivity. So back to your case, you informed me that you decided to proceed based upon her basal biology with dose-dense ACT in the adjuvant setting, followed by radiation. As you said, however, if you'd been able to obtain the data previous to surgery, you would have undertaken neoadjuvant treatment. And in that context, then, if the patient had had neoadjuvant therapy and was basal and had not achieved a PCR, what additional treatment would you have considered after that?
I'm not sure. That's a tricky question. I don't think I'm ready to offer Xeloda yet. I probably would just follow. I think it's, to me, if it's ER positive, I would still just follow likely just with endocrine treatment in that case. I probably wouldn't offer. I don't think I would be confident enough to say I'm offering any extra benefit. I probably just do endocrine treatment in that case, in the
Yeah,
adjuvant setting. It's more of an informative prognostic value to me. Yeah.
yeah, great, thank you. Well, let's move on to the third case, which is quite different from the other two, but I think is equally challenging.
So this is an older lady, 66-year-old, and had a screening mammogram, identified a left breast mass. And so on the ultrasound, it measured pretty large at 4.3 centimeters. And so on MRI scans, even larger and showed suspicious lymph nodes. And the tumor was biopsied, and it came back not high grade this time. It's low grade. Lymph node was also positive, just like the primary. And the tumor come back, ER very high, 95%. PR is low. HER2 is negative. Proliferation rate is moderate, pretty much on the low range.
Yeah.
Yeah.
So some slightly discordant features in the sense that the ER very strongly positive, grade 1, but then you've got quite a low PR, which calls into some question the biology of this tumor, and then a 2 plus a HER2 by IHC, sort of in the kind of a middle of the road Ki67. So would you, prior to doing genomic testing, would you be estimating that this patient may end up needing chemotherapy based upon some of these higher risk features on routine pathology?
But I probably lean towards a larger primary node positive. I would say probably. Yeah, I think not for sure, probably. Yeah.
So to clarify what to do, there are several questions here. So this is a patient with a clinical T2 or even T3 tumor. Not sure how many nodes are positive, but there appear to be several, but with some low-grade biology. Prior to having any genomic information, would your tendency be to take this patient directly to surgery or to consider some kind of neoadjuvant therapy?
A situation where the surgeon called me when she sent the case because she felt like she could resect it up front, but she want my opinion that would chemo be beneficial. So patient is okay to do mastectomy. So that's the reason I ordered genomic profiling, is if I think I can have a robust chemo response, very large tumor, multiple nodes, I would offer neoadjuvant treatment. If I know she's going to need chemo anyway, before or after, for a larger primary, there's some concern for margins, more nodes positive. So I would say I will offer the same chemo in the neoadjuvant setting rather than the adjuvant setting. It will be beneficial to the patient. So that's my vantage point of offering genomic profiling in this case to help me decide what do I expect of a chemo response.
Yeah. So if you were going to consider neoadjuvant therapy, in such a case, would it always be chemotherapy, or would you consider neoadjuvant endocrine therapy in some cases of these large, low-grade ER-positive cancers?
Yeah, and that's the thing. That's a personal deficit. I don't use a lot of neoadjuvant endocrine treatment. It's a practice habit. I'm still a little leery about. I use in my elderly patients more often. In more healthy, robust patient, I use it less often. It's not on my first my first choice. In my more elderly patient, I worry about chemotoxicity. I have used it before. More often, I still would go to chemo regimen generally. Yeah.
Okay. So in obtaining the genomic testing results, what you obtained was a mammoprint low-risk patient with an index of positive 0.163, which is the low-risk group that is not ultra-low. And not surprisingly, since most low-risk patients are luminal, she came back luminal subtype. So luminal A, not the lowest section of low risk, but still low risk. And let me again digress for a moment here. this subgroup within low risk is, as indicated by the MIND-ACT trial, a group that can avoid chemotherapy if they are T1 or T2 with no more than 1 to 3 positive nodes. But the other important finding, which was recently published, is that these are the patients that actually benefit from extended endocrine therapy based upon MammaPrint. And the data I'm referring to were just recently published in the Journal of Clinical Oncology, where we analyzed the NSABP B42 extended endocrine therapy trial. And I'm happy to say that we are soon to publish a second study that had been presented at San Antonio 2 years ago, the IDEAL trial. So let me take a moment just to talk about this relatively new use of MammaPrint, which is for endocrine management. Here's the paper that was published in July, the study in which we applied MammaPrint to the original B42 cohort. Now, you'll remember this trial. I think it was a very large adjuvant study exploring whether 5 years of endocrine therapy or 10 years of endocrine therapy were superior. Postmenopausal women who were stage 1, 2, or 3A were enrolled if they finished their first 5 years without any event or recurrence. And then they were randomized to an additional 5 years of an aromatase inhibitor, in this case letrozole, or placebo. And you may recall the original results of this study were positive, although not very positive. The disease-free survival benefit of the extended endocrine therapy with letrozole for 10 years was 3.3%. And so we were actually asked to analyze whether genomic stratification with MammaPrint could better identify who would really benefit from extended endocrine therapy. So when we applied MammaPrint, low versus high risk, to the B42 cohort and looked at disease-free survival and breast cancer-free index, we found, interestingly, that it was only the low-risk patients that benefited from extended endocrine therapy. When we separated low from high genomically, we now see a disease-free survival benefit of 7.8%, not 3.3%. And then, as we have studied in previous analyses, the ultra-low risk MammaPrint are patients who do exceedingly well even with less than 5 years. So we asked, if we take the low-risk group and further separate them into ultra-low and low, what do we see? Well, that is shown here. Again, disease-free survival, the low-risk group that is not ultra-low was the only one that achieved any benefit. In fact, the disease-free survival improvement was now 9.5%, a near tripling of what had been originally seen, with a very powerful, significant p-value. And here is a graphic representation of those numbers I was just describing. The original B42 cohort, where the overall benefit in the extended letrozole arm was 3.3%, but with the genomic stratification provided by MammaPrint and Blueprint, of course, primarily these were luminal patients by Blueprint, we showed that the only group that benefited was the group that was low risk, that was not ultra low, or high risk. Now, this is one large prospective randomized trial in which we did a retrospective analysis, but there's a second study, the IDEAL trial, which we also analyzed in the same way. These data were presented in an oral session at San Antonio 2022, where the study originally compared not 5 years versus 10, but actually 7.5 versus 10 of endocrine therapy in postmenopausal patients. And I'm happy to say that this study is also currently in press and soon to be published. But you may remember that this trial was a negative trial. They did not see, in an unselected approach to the population, any benefit from that extra 2.5 years beyond 7.5. But again, when we applied MammaPrint in this case, we saw no added benefit for the high-risk MammaPrint patients. But for the low-risk MammaPrint patients that were not ultra-low, even with an additional 2.5%, there was an absolute benefit of an additional 10% reduction in distant recurrence and improvement in relapse-free interval. So we now have these two studies showing the utility of MammaPrint and Blueprint in predicting who will actually benefit from extending endocrine therapy. So back to your case. did you try any neoadjuvant aromatase inhibitor therapy or go straight to surgery?
She, after the genomic profiling come back, her surgeon and patient talked, and they decided to go to upfront because I told them the chemo benefit would be very limited in this case with the profile. So she went ahead to surgery. Yeah.
Okay. And at surgery, the tumor was large, but surprisingly numerous positive nodes, 6 out of 16 positive nodes, which takes the patient out of that category from that MINDACT and actually other large node positive studies have looked at. So your post-op management?
We decided to give her taxotere-cytoxin chemo, but even though in this case, I still think the genomic profile data is beneficial because I would have thought about escalating patient regimens to include anthracycline in this case for a patient with that much disease. But with a profile, I'll be comfortable, not escalating and just take the anthracycline out of the picture. Yeah.
Well, she's clearly endocrine sensitive,
Mm-hmm.
certainly by the genomic profile. So would you be considering then extending endocrine therapy for this particular patient after she completes
Definitely.
her chemotherapy?
Definitely. Yeah. Yeah.
And then lastly, let's talk about CDK4/6 inhibitor because she certainly meets criteria for the use of CDK4/6 inhibitor adjuvant therapy. Because she's got multiple positive nodes, she meets criteria for abemaciclib. And as I think everyone has heard, based upon the NATALEE trial, the FDA recently approved ribociclib for even lower clinical risk patients, T2 node negative, as well as node positive patients. So you may have noticed, Dr. Ma, that the NCCN has actually stepped up and not only integrated ribociclib into guidelines, but they now call it preferred as the preferred aromatase inhibitor. I'm sorry, as the preferred CDK4/6 inhibitor. Does this development put any pressure on you to be using CDK4/6 inhibitors more broadly than you may have used them before?
I actually did not realize ribo is a preferred status over abema because I thought, even though the abema trial had a higher risk patient, that the improvement is a little more robust than the NATALEE trial. So it's a shorter length of treatment. Actually, my patients actually, if they qualify for both, their preference actually try abema first.
Yeah.
So I did not realize NCCN put in a preferred, but I definitely for this patient, definitely will be a strong candidate for CDK inhibitor. And the NATALEE trial now with approval ribo, I'll definitely use more on more patient population. Yeah.
Yeah. Well, certainly the data with abemaciclib in node positive, as well as ribociclib in node positive patients, strongly argues for adding these agents because these patients remain at high risk. But there's been certainly a lot of discussion about the need for a CDK4/6 biomarker, particularly if you start expanding the eligible population down to T2N0, which constitutes, as I've heard, as many as 35% of newly diagnosed breast cancers. That's a lot of patients being treated with these agents. So I wanted to close with this piece of information, and that is that MammaPrint High2, of all the genes that are in MammaPrint, one of them is cyclin E2, which is overexpressed at the very highest levels in High2. And we believe this may be relevant because cyclin E2 is one of the well-known resistance pathways for CDK4/6 inhibitor therapy. In fact, in a study that was published a few years ago, we looked at a set of genes that are included in the 70 genes in MammaPrint, all 3 of which are on chromosome 8 at Q22. They are in this area which is often amplified with all 3 of these genes, one of them being cyclin E2, which is, as you can see in the red box, expressed at the highest levels in MammaPrint High2, or ultra high as it's shown here, and may be involved in CDK4/6 inhibitor resistance. So we are actively interested in analyzing whether MammaPrint, in addition to the other information it provides, as well as blueprint, basal versus luminal, may be helpful as a biomarker in further clarifying who may or may not benefit from CDK4/6 inhibitor therapy, given the ubiquitous now use of these agents. Well, Dr. Ma, I want to thank you for these three very interesting and challenging cases and your very thoughtful therapy decision-making based upon not only, of course, clinical and pathologic data, but the additional value of the genomic data, which helped to underlie some of your decisions. So I want to thank you very much for providing these cases for our discussion today.